Hello, everyone, and good afternoon for the second day of Cocktail with Science. It's my great pleasure to have you here virtually in my city in Milano. And this Congress was planned in the middle of March, but unfortunately for the COVID, we couldn't be all together. So we tried to shape a virtual Congress that was human. So this Congress is dedicated to my group that you can see here. And you know that in Milano is a city where the aperitivo is a tradition. And so we wanted to create a Milano situation, and we sent to all the people the box with them. So in the middle of the Congress, we can celebrate all together. Finally, I would like to acknowledge in particular all the speakers of today. We have really a stellar panel also today, and I'm sure that it will be a great day, also a great second day. I would like also to say thank to these people, because behind all what you see online, there are these 5 people from events which were incredible in these days. And I would like also to thank all the pharma companies for the support to this event, and also all the scientific societies for the endorsement to the Congress. I hope that you will enjoy the day. Please be very active with the questions, and I leave the 2 chairs for the first session.
Good afternoon, everybody. Thank you, Marina. First of all, I would like to thank Marina for giving me the opportunity to be here as chair of this very interesting session, together with my friend Roberto Ferrara. Yesterday, we talked about advanced disease, oncogene and non-oncogene addicted. And today, we will talk about the early stages. What are the new achievements in the early disease in the last years? We will discuss this topic with a stellar panel, as Marina wrote, composed of some of the best international opinion leaders.
Okay, we can move to the first presentation of this Congress. It's a pleasure for me to introduce Professor David Carbone from Ohio Comprehensive Cancer Center. He will talk about novel neoadjuvant perspective in non-small cell lung cancer. Welcome, Professor Carbone.
Well, thank you very much. And it's a pleasure for me to discuss with you today neoadjuvant perspectives in lung cancer, and I'd like to thank all of you for the invitation to participate. These are my disclosures. As you can see, the outcomes after surgical resection for non-small cell lung cancer are less than ideal. Even with the very earliest stages, there's still a 10% mortality at 5 years. And on average, there's approximately a 50% mortality for resected lung cancer, even when the surgeon says he could get it all. So this is clearly an area that needs improvement. Adjuvant chemotherapy has been in use for many years, and these are just some of the studies of adjuvant chemotherapy after surgery. And you can see that even with the largest meta-analysis, the survival benefit is only approximately 5%. And the 2 studies that use cisplatin vinorelbine have maybe a 10% survival improvement, but still lots of room for improvement. Recently published phase 3 study of pemetrexed cisplatin showed that it was comparable to vinorelbine cisplatin. And interestingly, in this setting, that EGFR mutant tumors, when completely resected, seem to do a little better with the pemetrexed cisplatin compared to vinorelbine cisplatin. And pemetrexed cisplatin has really become probably the most commonly used regimen for adenocarcinomas in the adjuvant setting in the US. But what about pre versus post-operative therapy? There are a lot of small studies that compared that did pre or post-operative therapy. This was a meta-analysis published quite a few years ago that really looked at multiple studies and showed that there was no significant difference between pre and post-operative therapy benefits in this non-randomized comparison, but a small trend in favor of preoperative therapy. So how are therapies picked for combination with surgery? I think that generally speaking, they need to be shown to be effective in advanced disease. And this is typically by improving overall survival. Since surgery is a curative intent therapy, the intent of additional therapies in that setting, in my opinion, should be improving overall survival, generally not PFS. They need to be well tolerated enough to be safe for patients who may be cured already, since some patients after surgery need no additional therapy. And there's a real lack of robust biomarkers for selecting which patients need it and which don't. Immunotherapies clearly meet these criteria with improved survival, demonstrated very clearly in metastatic disease and generally well tolerated. And in fact, when combined with the curative intent chemoradiation, there is a very clear survival benefit, suggesting that it might also be seen with addition to surgery. But these agents, in contrast to cisplatin and vinorelbine, for example, come at a strikingly high cost, especially when half the patients get many months of therapy or sometimes years of therapy and didn't actually need any treatment. Targeted therapies are a different story. They might meet these criteria. Clearly, they show a benefit in PFS. Some studies are showing a trend toward overall survival. But again, the question is still out, I think, about neoadjuvant and adjuvant targeted therapies. So what are the advantages of pre or post-operative therapies? I think both have the disadvantage that you're treating a lot of people who are already cured and don't need it, that there are no robust biomarkers except possibly ctDNA. I think there are multiple studies showing now that ctDNA detection post-operatively is a very strong predictor of relapse and might be rationally used to select adjuvant therapy. There are multiple potential advantages for post-operative therapy. One is that there's no delay or interference with the most effective regimen. Clearly, surgery is the most effective regimen in this setting. There's also the longest experience with this type of therapy, and patients generally don't like to delay surgery. They've just found they have lung cancer, they want it out, and telling them that you're going to give them something that may or may not shrink their tumor before surgery is not a very attractive option for them. For preoperative therapy, there are advantages that allow you to assess the efficacy of the anti-tumor intervention before surgery. you can tell if what you're doing is shrinking the tumor or not. And it may actually allow you to treat early micrometastatic disease. And especially in the context of immunotherapies, it may be important to have intact tumor and intact nodal drainage to optimize the benefit for immunotherapy. And as a scientist, I think it is important that that neoadjuvant therapy gives you access to pre and post biospecimens to better understand why one patient benefits and another doesn't. There are some in vitro laboratory data that suggest that treating early stage lung cancers in a neoadjuvant setting before resection, this is just one paper, the Cancer Discovery, suggesting that the induction of the immune response is more effective when treated in a neoadjuvant setting. And these are just examples of selected trials of adjuvant therapy in non-small cell lung cancer. I'll focus today on neoadjuvant immunotherapies. These are just some of the ones that are ongoing or finished. And I'll skip that one. This is a duplicate. So these are just examples of the phase 3 trials of neoadjuvant immunotherapy from each of the major companies. All of these are combinations with chemotherapy, and they have a variety of primary endpoints of event-free survival, PCR, MPR, etc. And unfortunately, as with all things related to adjuvant or neoadjuvant therapy, it takes some time for the readout to be apparent. And this is just a timeline of potential readout times for different studies, some of which the results won't be available for another 5 years. There was one disappointing result recently of a phase 3 adjuvant trial in bladder cancer that was negative and did not meet its primary endpoint of disease-free survival, and this is disappointing. I would be very surprised if the adjuvant immunotherapy trials or neoadjuvant immunotherapy trials don't improve survival in lung cancer, but I was surprised by this result as well. So, what are the early results of these studies? This is just a table of some of the reported phase 2 results. This is reporting major pathologic responses in multiple studies of 20 to 80%, with objective radiographic responses also very high. This is the first published neoadjuvant nivolumab trial published by Dr. Ford, and shows a very high major pathologic response and a few cases of complete pathologic response, giving us hope that this approach may be effective. There was a randomized study called NeoStar run by Tina Casconi at MD Anderson that randomized between nivolumab, Nivo-Ipi, and Nivo plus chemo before surgery, and then used adjuvant, standard of care chemo with or without radiation, no adjuvant immunotherapy. And this is just some of the results from that. With the nivolumab alone, the MPR plus PCR rate was 17%. But if you look on the right, the Nivo-Ipi treatment had 6 patients with a pathologic complete response. I think I missed a slide there. This was a study of a novel anti-PD-1 called sintilimab in neoadjuvant setting, and showed a striking major pathologic response of 40% with a 16% pathologic complete response. This was reported at the 2019 World Lung Cancer Conference. Another study combining nivolumab and chemotherapy called NADIM had an incredible 83% major pathologic response rate and a 59% complete pathologic response rate. This is the approach, the chemo-immuno approach is the one used in most of the phase 3 studies. They looked in that study to identify factors associated with pathologic response, and none of the clinical parameters seem to be associated. So again, emphasizing the need for better biomarkers. So this is a study that I am leading through the LCMC3 with Valerie Ruch as the surgical co-PI from Memorial. This is a neoadjuvant trial of atezolizumab, 2 cycles, 3 weeks apart before surgery, and then standard of care adjuvant therapy, followed by a year of adjuvant atezolizumab. And this study was designed from the beginning to collect biospecimens and do intensive biomarker analysis. 183, the study is fully accrued with 183 patients on trial, and we're going to be presenting the final clinical analysis at World Lung and probably the preliminary biomarker analysis at AACR next year. Some of the presented biomarker data from the first 60 patients or so showed that we didn't see a strong correlation with tumor mutation burden in the upper left, but we clearly had a good pathologic response with 22% achieving MPR and 3 patients achieving pathologic complete responses at the time of surgery. And I found it very intriguing that we also found preliminary correlations of baseline immunophenotype of peripheral blood with major pathologic response, and this just shows 2 subsets of cells that were statistically significantly correlated with MPR. And this will be elaborated with the additional patients in the full study set, only 60 patients. And this is, I think, the largest study of neoadjuvant monoimmunotherapy. We also have recently completed a neoadjuvant immunotherapy before chemoradiation in the curative intent setting. This is AFT16, where we would give, in fact, 4 cycles of atezolizumab before chemoradiation and then an adjuvant atezolizumab as well. This study is a 60-patient study that's completed accrual, and follow-up is ongoing. The results haven't been reported out yet. So when it comes to neoadjuvant immunotherapy, I think it's a great biomarker platform, really promising scientific and clinical early data coming out of these studies. And I really think that the science will help improve patient selection and tailoring these therapies for individual patients. I think there's as I said, multiple theoretical clinical advantages to treating with immunotherapy in the neoadjuvant setting. I think we've proven that it's practical and safe, and that we could use the neoadjuvant response to select patients for adjuvant immunotherapy, which would save toxicity and cost to the healthcare system. However, most current neoadjuvant trials use IO plus chemo, where it's a little bit less clear whether you're getting benefit from the IO or not. And while there's improved response rate, there's also the liability of chemotherapy toxicity, and I think less utility for studying the biology of immunotherapy. So what about targeted therapy? I think it's very clear that you get dramatic responses from TKIs in EGFR mutant tumors. This is a study published in 2015 of neoadjuvant erlotinib in stage 3A and 2 disease, and shows a very dramatic response and frequent responses in these patients. But surprisingly, actually a worse survival for patients treated with neoadjuvant erlotinib compared to chemotherapy. Now, it's a tiny number of patients, and no adjuvant therapy was given. But you would think that at least they would be equivalent in terms of outcome with this dramatic response rate. So a larger study was done with by the same author with neoadjuvant and adjuvant targeted therapy. And this showed, again, a very impressive tumor regression before surgery. But again, in this case, even with adjuvant therapy, no survival benefit was observed, and only 20 or 30% of patients were alive at 5 years, which is not that different from what you see with chemotherapy and radiation in this setting. And so, of course, the big news recently is ADAURA with osimertinib, which has multiple potential advantages over erlotinib, especially in the CNS. But we await the overall survival data from this study. This is, of course, adjuvant, and it would be, I think, premature to move this into a neoadjuvant setting, and we all await the overall survival data here. But in spite of that, it was recently approved in the US. So what about other drivers? There's a study that's just opening now called LCMC4 that attempts to define drivers and subpopulations before surgery and treat with the appropriate targeted agent in the neoadjuvant setting, and follow with ctDNA. And I think this study will potentially answer both scientific and clinical questions for multiple drivers, because I do think it's a mistake to lump all drivers in the same bucket. The outcomes for each, I think, needs to be tested independently. So in general, I think that TKI combination with surgery is not as clear as you might think. I'm not convinced that DFS is a true surrogate endpoint for overall survival in a surgical population where cure is the intent and not just disease suppression. And I think this is especially true when 3 years of treatment is given and 3-year DFS is the endpoint. TKIs are currently being tested in combinations as well with platinum and anti-angiogenic and IO, and we await the results of those data. And I think regardless of what therapy you're choosing, expensive TKIs or expensive immunotherapies, we need to select patients who need the therapy. And so I personally am very encouraged by the use of ctDNA. And of course, cost and duration of therapy are issues. What about other agents? This is results of the CANTOS trial with IL-1 beta antibody, canatumumab. And this was a many thousand patient study. And one of the most striking outcomes of this study, as most people know, is a reduction in lung cancer deaths in a dose-dependent manner with canatumumab. And so this is being tested in a therapeutic setting right now in multiple phase 3 trials. But there's also a neoadjuvant canakinumab trial shown here, which randomizes patients before surgery to canakinumab plus pembrolizumab and pembro alone. And this trial is ongoing. So in summary, for systemic therapy of resected lung cancer, I think it's very clear chemotherapy has a survival benefit and should still be the standard for patients with completely resected tumors. But the overall survival benefit really is discouragingly small. Adjuvant therapy with TKIs may be an option for EGFR mutation positive tumors, but there are a lot of caveats, and the role in the neoadjuvant setting is not known, with the data that is available being not particularly encouraging. But incredibly, it's pretty clear that neoadjuvant TKI alone is a bad idea. Immune checkpoint inhibitors are very promising as induction or adjuvant therapy in combination with chemoradiation therapy in stage 3, and provide an outstanding platform for translational science studies. But it's really important for us, especially with these TKIs and the immunotherapies, to be able to select the patients who really need therapy. And I think right now, ctDNA is the best candidate. And of course, I haven't touched upon it, but a really big question is if you treat a patient with chemoimmunotherapy and surgery, and they relapse a few months after surgery, how they respond to first-line systemic therapy, or are we treating them with docetaxel as first-line metastatic disease? So thank you very much. It was a pleasure to talk to you virtually. I do miss visiting Milan, and hopefully we can do that next year.
Thank you very much, Professor Carbone, for your great talk. I will let the questions at the end of the presentations. And just a reminder for the audience, please, you can write your questions and we will ask them at the end. So, moving on, I have to say that I am quite excited for both the next topic and only reading the names of the speakers. And could target therapies have a role in early stages non-small cell lung cancer? Why yes and why no? Yesterday, Professor Gagil talked about the DORA trial as one of the most important presentations at ASCO in the last years. And today we have the honor to have with us the presenter, the first author of the trial, Professor Roy Herbst from Yale Cancer Center, who will say why yes.
Hi, do you hear me?
Yeah.
Yeah.
Thank you. I'm in the middle of clinic here, so I apologize for not being as formal as I could be. And of course, like David, I wish that I was in Milan. So I'm going to talk about, is there a role for targeted therapies in early stage non-small cell lung cancer? And my answer is an emphatic yes. Next slide, please. So I'm basically going to give a update of osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive non-small cell lung cancer after complete tumor resection. This is the ADORA trial, and there'll be an update of this just in a week and a half at the ESMO meeting in the presidential symposium by Dr. Suboy. But I'll give you the data to date and hint a little bit at some of the new things to come. Next slide. So we've probably not necessary at this time in the meeting, but certainly, we're dealing with such a major problem, and even with only 10 to 15% of patients in the Western world having EGFR mutations and 20 to 30% in Asia, still a lot of patients that have EGFR mutated disease. And the problem is, in early disease, you can see the little schematics, even after surgery, patients have a very high chance of having a recurrent disease. So it's very important that we identify this early and we treat it appropriately. Next slide. So surgery, as I mentioned, is a primary treatment for patients with early stage non-small cell lung cancer. Adjuvant cisplatin-based therapy is recommended in patients with resected disease, certainly most patients with stage 2 to 3A disease, and many patients with stage 1B. Now, we know from a number of meta-analyses and from studies that the 5-year benefit with adjuvant chemotherapy in patients with lung cancer is real, but moderate. Overall survival hazard ratio 0.89. DFS also favored adjuvant chemotherapy, hazard ratio 0.84. And a small subset from the JBR10 did show in about 30, 40 patients, a very significant benefit with chemotherapy in EGFR mutated patients, something to keep in mind. Overall disease recurrence or death remains high. So looking through a number of worldwide databases would estimate about 45% of patients with stage 1 disease will have recurrence, 62% of patients with stage 2 disease, and as many as 76% of patients with stage 3 disease. So very, very high levels. So in the next slide, we set out to do a trial to bring EGFR TKIs and bring them to earlier disease. Now, this is a very special endeavor for me because as a young assistant professor at MD Anderson in 1997, 1998, I actually did some of the earliest trials with gefitinib and erlotinib. And now over 20 years, we've seen that we've moved from second and more line treatment without a biomarker to the discovery of EGFR mutations to frontline treatment using biomarker. We now have osimertinib, a third-generation EGFR TKI, statistically significant and clinically meaningful improvement in PFS and OS compared to the other TKIs, the first generation, erlotinib and gefitinib, also having activity in the central nervous system. And the efficacy and safety profile of osimertinib in EGFR-mutated advanced lung cancer suggests that it may be an effective treatment for patients with early disease. So the funnel has moved, targeted therapy with a target to early disease, a paradigm that I would contest is one we need to see more of, in not only with this target, but just today another RET inhibitor is approved in the U.S. All these small subgroups of patients, they would benefit, I would believe, from this type of approach. But today we're discussing EGFR. Next slide. So here's the ADAURA trial, it was for stage 1B, 2, or 3A disease, with or without adjuvant therapy. So this was based on physician and patient choice. We can discuss that. The key inclusion criteria: age 18 or more, greater than 20 in Japan and Taiwan, performance status 0 to 1, confirmed primary non-squamous non-small cell lung cancer, 2 EGFR mutations, the most canonical ones, 19 deletion and L858R, exon 21. Brain imaging was done, if not completed, preoperatively. Complete resection with negative margins. And the max interval between surgery and randomization was 10 weeks with adjuvant therapy, chemotherapy, and 26 weeks without adjuvant chemotherapy. Next slide, please. So here you can see the stratifications. There were 3 by stage, 1B, 2, or 3A, and these were about equal, 1 to 1 to 1. By mutation status, exon 19 deletion, or L858R, or the race, Asian versus non-Asian. About 2/3 of the patients were Asian. And then patients were randomized to osimertinib, 80 milligrams once daily, the standard dose, or a placebo once daily. 682 patients. Why a placebo trial? Because as you all know, prior to this, there had been no demonstration of any TKI or any EGFR inhibitor having a benefit in this setting. The RADIANT trial, for example, was negative. So this was the reasonable control. Next push, please. Will show that the planned treatment duration was 3 years. Why 3 years? Well, we know that this is a more effective, more cytotoxic inhibitor. The feeling was 3 years, a little bit longer than what was used in RADIANT, which was 2 years. It could be well tolerated, so 3 years was chosen. I guess you could always make the case, why not give it longer? And I think people will discuss that after this trial is published. Treatment continues until disease recurrence, treatment is completed, or discontinuation criteria are met. What's the follow-up? Very close follow-up until recurrence, week 12 and 24, then every 24 weeks to 5 years, then yearly, and after recurrence, every 24 weeks for 5 years, then yearly. And it's still being actively followed up, even though the top-line results have been reported. Next slide. So you can see that this trial, the primary endpoint was disease-free survival by investigator assessment, because it was blinded, in stage 2 and 3A patients, designed for superiority with an assumed DFS hazard ratio of 0.70. So we would have accepted a 30% benefit. Keep that in mind. Secondary endpoint was DFS in the overall population, so that adds in those curves. And then disease-free survival at 2, 3, 4, and 5-year landmarks. Overall survival, of course, still being studied, safety and health-related quality of life. Following an IDMC recommendation, the study was unblinded early due to efficacy. And here, this is the unplanned interim analysis. I wasn't expecting it this year. I received April 10th that the trial had been unblinded. I was surprised as anyone. At the time of the unblinding, the study had completed enrollment, and all patients were followed up for at least 1 year. So everyone had been through at least 1 year, but it was an early result because the Data Monitoring Committee took it into their hands to see that the results were so compelling, they felt the trial ethically had to stop. So in the next slide, this is the baseline characteristics. Nothing much to say here. You can see, male, female, more women than men on this trial. The median age, about 64, the same in both groups. You can see we have smokers and non-smokers both on this study. As I said, about 64% were Asian. Most of them had performance status 0, but 0 and 1 were allowed. You can see the staging equal in both arms, about a third. Histology, everyone was supposed to have adenocarcinoma. I guess a couple of the reports are NOS, not otherwise specified. EGFR mutation at randomization, a little bit more than half had the exon 19 deletion. And this one is very important, and if you click again, I think I have it highlighted, you'll see that adjuvant chemotherapy, please press the button for the next slide. Adjuvant chemotherapy, yes, no, 55 versus 45% in both groups. So equal use. As you would imagine, most of the 2s and 3s, over 80%, had adjuvant therapy. A very small percentage of the 1s averages out to about 55%. Next slide, please. So here you go. This is what we saw as the steering committee, myself, Dr. Suboy, Dr. Wu. Dr. Suboy, as I mentioned, will be updating this at ESMO in a few weeks. Just amazing. Survival curves, disease-free survival curves like this, the upper curve blue being the osimertinib, the yellow being the control. Take a look at the landmark at 2 years, 90% versus 44%, a 2-to-1 improvement. The hazard ratio across the entire curve is 0.17 with a highly statistically significant p-value. Now this is at 33% maturity, 11% mature, meaning events having occurred in the osimertinib arm, and 55% in the placebo arm. So really a very compelling result. Remember, I said we would have been happy with 0.3. I would have even taken 0.4, 0.5, or 0.6. But look at 0.3, 0.7. Excuse me. I would have taken even lower than that. But here we have 0.17. So 4 or 5 times better than expected. You expected this trial would be positive, but at this magnitude, really incredible, unparalleled results. Next slide. So here's the on the next slide we have the secondary endpoint, key secondary endpoint, the entire population. And I don't see the next slide switching, so I'm going to slow down. Can you go back? Back when? I apologize. Okay, yeah, here it is. My computer must have a lag. Sorry. It would be better to be in Milan, wouldn't it? So here you can see the stage 1B, 2, and 3A. So now you've added those patients in. And even with adding those patients in, you can see 89% versus 52% at 2 years. Hazard ratio 0.21. P-value highly statistically significant. As you would imagine, a little bit less mature. But even when you bring in the patients with stage 1B disease, many of whom are cured just with surgery, look at the result. Still quite compelling. Now, let's look at a forest plot, and that's on the next slide. We already had a little preview. And, everything to the left of 1. So whether it be sex or age, smoking status, race, even the stage 1B makes it. And you'll see an update on that and in a few weeks. And I think it continues to look good. And then you can see stage 2 and 3. The benefit is a little bit higher as we advance the stage, as we've seen in other trials. EGFR mutation, benefit in both of the types of mutation, exon 19 and 21. And then adjuvant chemotherapy, very important. The benefit is seen hazard of 0.18 or 0.23 in both having had adjuvant or not. So very nice DFS across subgroups in the forest plot. Next slide. So here in this next slide, you can just see that the adjuvant chemotherapy is highlighted, as I already did. So then we'll go to the next slide. And here you can see DFS by stage, just broken out a little bit. So in the osimertinib arm, 2-year disease-free survival rates were consistent across stage 1B, 2, and 3A. So you can see 87, 91, 88. But it's the placebo group. That's where you see things going down, 73, 56, and 32, leading to the hazard ratios of 0.5, 0.17, and 0.12 in the 3A. Maturity, as I mentioned, in the overall population was 29%. Next slide. So here you can see on the next slide, here's the stage 1B curve. And again, even at this early time point in a stage of disease with such good prognosis, still a significant hazard ratio. Stage 2, with the next click of the button, please, you can see 0.17, sort of consistent. This is sort of where most of the curves are. And then if you go to stage 3A, it's 0.12. And you can see the biggest difference being in the stage 3A patients with the next click of the button, please. And there you can see the 3As. So really, really very, very compelling data. Next slide. Now this is a debate. So the next speaker is going to tell you we don't have survival yet, and we don't. And how could we? Trials are unblinded 2 years early. So that's going to be important to follow and maintain. The trials unblinded at the level of the study, but not at the level of the patient. So patients remain blinded, and they're continuing to be followed. I'll also point out we're getting blood on these patients. So we'll be able to look at, David was just mentioning some of the techniques to look at biopsies and things that we can use. All this is still included and active in the trial. And you can see, however, I'm just going to show you at the time that we analyzed, this is the survival curve, and looks okay, but maturity 5%. This needs follow-up, and it will be followed, and it's going to be important to follow it up. But in the meantime, look at those disease-free survival curves as you think about whether this should be a standard of care. Next slide. Now, toxicity is always important, and a few new toxicities appeared in this trial compared to what was seen with osimertinib in the past, because it was being compared to placebo in a large study in patients who didn't, many of them didn't have very many other side effects. We learned a little bit more about this drug, but for the most part, it was really well tolerated. And if you look with the next click of the arrow, so the next slide, please, you'll see there's some animation that will come in. And you can see AEs greater than grade 3, 20% in the osimertinib arm, and 14% in the placebo arm, so 68 versus 48. And then if you look down a little bit, any AE leading to discontinuation, 38 versus 15, or 11 versus 4%. So slightly more, but not that many. And AE leading to dose reduction, 7 versus 1. So some and this is an EGFR tyrosine kinase mutation-specific drug, but still a little bit of side effects, but well tolerated, and certainly didn't affect the ability of these patients to get their treatment for longer periods of time. Next slide. And here's a tornado plot. And a tornado is a little bit better way, I think, of looking at it. And here I have the median duration of exposure, which I wanted to mention actually before, 22.3 months, range 0 to 43. Again, this will continue to be followed. If you go back on that last slide, you can see that the left is osimertinib, the right is the placebo. So a little bit more diarrhea, but mostly all low grade, only 2% high grade. a little bit more paronychia, as you see with these drugs, but only 1% high grade, more stomatitis, but again, most of it low grade. Same with decreased appetite and URTI. So upper respiratory tract infection. So you can see very mild increased toxicity, very, very important. Grade 1-2 interstitial lung disease was reported in only 3% of patients, all low grade. This is the reason radiation wasn't included in the study. We were concerned about that. QTc prolongation was reported in 7% of patients in the osimertinib arm, and 1% of patients in the placebo arm. So just getting to the concluding slides. Next slide. There's more to be learned from this trial. Masahiro Tsuboi will be presenting local versus distant recurrence in just a few days. And I think there was a press release out this morning that sort of foreshadowing this. You're going to be hearing about the brain, and that's going to be pretty exciting. So stay tuned for that. Preventing disease-free survival is one thing, but to prevent metastases to the brain, we know this drug is active. That's going to be important. And of course, all the sites of metastases and local versus metastatic will be discussed. The effect of subsequent therapies, that's being analyzed and looked at right now as well, and quality of life. And you'll probably hear from one of us, probably Yilong, later in the year to hear about the updates, probably at the World Lung Conference. So much data to look at as we await the survival. And this trial is being continued to follow for survival. So the last slide, my conclusions, before I give the other speaker a chance to give the other side. On the next slide, please. Adjuvant osimertinib is the first targeted agent in a global trial to show a statistically significant and clinically meaningful improvement in disease-free survival in patients with stage 1B, 2, and 3A EGFR mutant non-small cell lung cancer. Overall, there was a 79% reduction in the risk of disease recurrence or death with osimertinib. Disease-free survival hazard ratio is 0.21. That's the overall population. And for the overall population, 89 versus 53% for DFS of 2 years. Consistent improvement, whether or not the patient received adjuvant chemotherapy. We're going to dig more into these data, don't worry. But right now, equal across the groups. Safety profile consistent with what has been seen before. As I showed you, very mild toxicities, mostly grades 1 and 2. So concluding line, adjuvant osimertinib will provide a highly effective, practice-changing treatment for patients with stage 1B, 2, and 3A EGFR mutant non-small cell lung cancer after complete tumor resection. So with that, I'll give you my last slide, which is the most important because it acknowledges all the investigators and patients around the world, the amazing teams at AstraZeneca, and those who helped us with these slides and with all the work that needed to be done. An amazing IDMC. Many of you have served on these, and you've probably stopped trials for futility, but to stop it for efficacy at an unplanned analysis took a little bit of work, and I thank them for that. So thank you all. It's a pleasure to be here. I look forward to the continued discussions this evening over cocktails. Thank you.
Thank you very much, Professor Herbst, for this interesting talk. We will keep questions at the end of this session. So now it's a pleasure for me to introduce Professor Benjamin Besse from Institut Gustave Roussy, Villejuif, France, and he will explain us why there is no role for adjuvant target agents in early stage non-small cell lung cancer. Welcome, Professor Besse.
Thank you, Roberto. Such a pity not to be in Milano. It was impressive data presented by Professor Herbst, but this is a controversy, and I might be a bit controversial about these results. So these are my disclosures. And let's go back to the basic. What is adjuvant chemotherapy or adjuvant treatment goal? The goal is to destroy the micrometastasis. And by destroying micrometastasis, you cure more. So the only goal of an adjuvant treatment is to destroy micrometastatic and cure more people. And with adjuvant chemotherapy, it works. Targeted therapies, well, there are a lot of those targeted therapies. Bevacizumab is a targeted therapy against VEGF, and in the adjuvant setting, it's not efficient. Why? Because bevacizumab there did not destroy the micrometastasis. So let's see what happened in the EGR field, because although the title is targeted therapy in early stages, The EGFR case is, of course, what we are very interested about because of the ADORA results. So let's go back to the first results and go back to the first results of randomized trial of TKI versus placebo. Well, let's start with stage 3, treated by chemorad. Very interesting data. All the patients at stage 3, chemorad, 3 cycles of docetaxel, and then randomized between placebo or gefitinib. And gefitinib was given up to a progression. Primary endpoint was progression was overall survival, and the trial is positive. But the positive effect is a detrimental effect. So here, the median overall survival is cut by 1 year because the patient received gefitinib. What happened there? Well, this is a study that included patients before all the EGFR mutations studies, so it's an unselected population. And what happened to a tumor that received 61 grays and then can survive to 61 grays? Well, probably a lot of additional mutation that might change the sensitivity profile to TKI. And of course, there might be a lot of imbalance because at that time, smoking status, EGFR mutational status was not captured in the CRF. But just to say that what you see in the metastatic setting is not something that you can automatically translate in the adjuvant setting. Well, the first study that we have seen in the adjuvant setting after resection of stage 1B to 3A non-small cell lung cancer is the BR19 study, where gefitinib was compared to a placebo. Gefitinib was given for 2 years, but it was in an unselected population. So you have at the left side the overall survival in the intent to treat population negative, but again, we know today that this is the patient with EGFR mutated and LCLC that are the target of these drugs. So there is a very, very tiny subgroup that was analyzed. It's a post-hoc analysis. Look, only 15 patients, so 4% of the total population. You can't conclude nothing on that. The Radiant study compared 2 years of erlotinib to 2 years of placebo in the same population. The primary endpoint was DFS. And there, the EGFR subgroup is significant. 16.5% of the whole population. The two curves you see is just the curves of the EGFR mutated population. As you can see, the DFS is very impressive. Hazard ratio 0.6. Absolutely no translation in the overall survival. Why? Well, maybe some of the patients received in the placebo arm an EGFR TKI at relapse. The recruitment was between 2007 and 2010. I might remember you that the EGFR mutation was found in 2004, and the approval of gefitinib for the mutated NLCLC patients was in 2009. So we can expect that some of these patients received a TKI at relapse, and then there is no benefit in the overall survival. And this is a key feature for the EGFR field. Can the patient at relapse maybe treated with an EGFR and then OS is not significant anymore? Well, let's move at a second type of trial that compare EGFR TKI to chemotherapy. Well, here we have two main trials. The two trials were run in China. IVAN trial in stage 3A, 2 years of erlotinib or a chemotherapy, and the CTONG trial, it's the CTONG 1104, but I will just say CTONG, that compare in stage 2 and stage 3A resected NSCLC patients, 2 years of gefitinib or chemotherapy. In the first thing that we can see here is that if we look at this DFS curve, well, although there is a benefit in the TKI arm, it's a bit scary. It seems that all the patients recurs at what point? Well, what happened here? Well, we have some stage 2 here, and even in stage 3, not all the patients should recur in the control arm. So what you can argue here is, what is the quality of the surgery? Well, the resection was complete, but did the patient had a node resection, for example, well, we don't have any information of the quality of the surgery. So it might be an issue, and an issue of poor quality surgery. The second question you might have is, what is the initial workup? Well, in the CTONG study, we have the numbers, and only 24% of the patient had a PET scan. Well, can you conceive today to have a patient that undergoes surgery without a PET scan? No, you can't. Why? Because when you perform a PET scan, you know that 1 patient out of 3 that would undergo surgery with just a CT scan will be eligible for a surgery with a PET scan. 1 patient out of 3 is in fact metastatic on the PET scan. Can you imagine the data that we have here? 3 out of 4 patients had no PET scan. It means that a lot of those patients are in fact macrometastatic patients. And if you look at the brain MRI, only 16% have a brain MRI. Well, that can explain these very beautiful DFS curves. It was just improper initial workup. What about the event? Well, we just don't know the data. Maybe no patient had a PET scan. It's a key question when you look at a patient and a study of surgery. Well, you can translate that in a way if you look at the stage where, if you look at this stage in event, well, the bigger the tumor is, the stronger the benefit is. Well, maybe it's DFS, maybe it's the bigger the tumor is, the more macrometastasis you have. Of course, you don't know, you don't have enough PET scan. What about in the CTONG study? Well, you have the end stage again, when N was positive, while N2 versus N1. Well, the benefit was very, very much stronger, because you can expect that a lot of N2 patients without PET scan are in fact metastatic patients. So let's just look at the DFS and OS data for the EVAN. So EVAN is 2 years of erlotinib versus chemotherapy in stage 3A. Again, we don't know how many of these stage 3A had a PET scan. Well, there is a benefit, a clear benefit in terms of DFS, and that translates in a benefit in terms of OS. But my question here is that, okay, so we know that some of the patients relapse, most of the patients relapse, it seems, in the control arm. How many of those patients receive TKI at relapse? We don't know. We don't know. We know that the study enrolled between 2012 and 2015. So in 2015, the access to a TKI should be easy, but this is a study in China, and I don't know how much of these patients had an access to a TKI. Let's do the same thing with the CTONG study. CTONG, again, we have bad DFS curves in the early results that were published in the Lancet, but it was updated at ASCO this year. And the first good news is that all the patients do not relapse. With a longer follow-up, you have the proof that roughly 80% of the patient relapse, which is still significant, but not all the patients relapse. What about the OS data? Well, there no benefit in OS. And look, in the control arm, at relapse, around half of the patients received the TKI with EGFR. Okay, so half of the patients received the TKI, while those that received chemotherapy, we know already that they have an EGFR mutation because they were randomized in the adjuvant setting. So the patient has the test in hand. So when he relapses, he knows that he has an EGFR mutated, he should receive, in almost 100% of the case, a TKI. This is standard of care at first line. Here, it's only half of the patient, and we have the same overall survival curves. Imagine this curve with 100% of the patient that would receive the TKI. What would you accept? Well, you should think that if 100% of the patient receive the TKI in the chemotherapy arm, probably the overall survival of the chemo arm would be superior to the adjuvant TKI arm. It's key to know if the patient received the proper treatment at relapse. Well, you can say maybe it changes the course of the disease. Well, from the event trial, we have the information that, for example, the rate of brain metastasis was not that different between the group of patients that received a TKI or a chemotherapy. But of course, we have heard Professor Herbst. Professor Herbst just told you that he made Adjuvant great again. Well, it was a tremendous, an amazing study. So let's look at what ADAURA add to the field. Okay, a bit of perspective on ADAURA. Well, ADAURA included stage 1B, stage 2, and stage 3A. But the primary endpoint was DFS only in stage 2 and 3A. Well, look, like in other studies, the larger the stage here, the stronger the hazard ratio here, but we analyze only stage 2 and 3A. And my first question is, well, are there real stage 2 and 3A? What is the percentage of RMI? What is the percentage of PET scan? Well, we don't know. We don't know. So if we don't know that, it means that some of these patients are in fact stage 4 patients. Well, ctDNA at the post-surgery would be very informative, because we know that in some patients you can still find ctDNA in the blood post-surgery, meaning that in fact they are still they still have some disease, so they are metastatic patients. So it would be a very good thing to see what are those patients with let's say post-operative bulky disease or really micrometastatic disease. Very interesting tool. Well, you can also say that, well, at 3 years, 23% of patients did not relapse in the control arm. This is not so good. So what happened there? Well, you can say, oh, you know, EGFR mutation is a poor prognostic factor. Well, it's not true. The patient with EGFR mutated and LCLC has the same overall survival that the patient resected with an EGFR wild-type tumor. So it's not a prognostic factor that explains why we have this very, very poor DFS in the control arm. Again, if we go look compared to the CTOM study, it's not very proper to do that, because it's not exactly the same patient. It's stage 2 and 3A anyway, and they have the same DFS at 3 years in both control arm. And I remember you that in the CTOM study, only 24% of the patients had the PET scan, and that we don't have this information in ADAURA. Maybe the EGFR subtype matters. We know that in the ADAURA study, the benefit was mostly seen in the patients with exon 19 EGFR, when the CTOM with gefitinib, the benefit was similar for exon 19, exon 21. This is something that we will look in the future. We know that in the metastatic setting, in the FLORA study, the difference of activity of osimertinib is quite different between exon 19 and exon 21, something to follow in the future. Well, we have overall data curves. I put you here, the patient in the experimental arm received roughly 22 months of median osimertinib. Look, the first event you see in the control arm are post the treatment period. So my concern is maybe osimertinib is not it's just a cover on the disease, and when you stop the treatment, you recover the cover and the disease is there and explode. So, well, we will need no maturity. Well, we know, Dr. The study is adorable. He also did the Italian version, Adorabile. And very rapidly, the perspective, DFS is a surrogate for OS. It's true, but it's true for adjuvant chemo. This is an example of stage 4. Benefit of PFS translate for benefit in OS. In the early disease, benefit of DFS translate in OS for chemo. DFS is a surrogate of endpoint for OS. It's true. TKI, we don't know. This is an example of adjuvant imatinib study. Benefit in DFS for GIST, no benefit in overall survival. So we are not sure it's the true. Oh, adoration of aura, okay, but let's look at more mature data because what we have seen with the optimal study is that in the metastatic setting, chemo versus erlotinib first line induce a PFS with another ratio of 0.16. So exactly what you see in ADORA, but the overall survival was negative because 70% of the patients in the chemo arm crossed over to an EGFR TKI. So my real question is, okay, the DFS is impressive, but if 100% of the patients that relapse receive a TKI in the control arm, will overall survival be positive? So my conclusion is that my goal in the adjuvant setting is not to delay the relapse, it's to cure more patients and then increase overall survival. In the adjuvant setting, we want to destroy micrometastatic and not rescue a poor local treatment where surgery is not optimal, and we need this data from this trial. We don't want to treat macrometastatic. We need a proper workup at study entry with a PET scan pre-surgery and with a brain RMR. So we need more time to interpret ADORA. ADORA needs more maturity for the OS data, and I really hope that knowing that all these patients has EGFR mutated tumors, they will all receive an EGFR TKI at relapse. I thank you very much for your attention.
Thank you. Thank you very much, Professor Best, for your adorable presentation. I think that the fight between yes or no about the role of target therapies of EGFR TKI in non-small cell lung cancer is still debatable and remains still interesting. So, moving on, next topic. What is the role of biomarkers for early detection of lung cancer? Next speaker is Professor Licia Sequist from Harvard Medical School and Massachusetts General Hospital in Boston, who will talk about the role of ctDNA. Welcome, Professor Sequist.
Hello, I'm Licia Sequist from Massachusetts General Hospital in Boston. Thank you so much for having me here virtually to discuss with you today the role of ctDNA in lung cancer early detection. Here are my disclosures. So as the audience is familiar, finding lung cancer early is a high priority as the cure rates with stage 1 lung cancer are much better than what we normally see with the majority of patients who present when symptomatic with advanced stage disease. Of course, over the last 10 years, and especially the last couple of years, we've seen a lot of advances with the increasing proof that's been offered by randomized trials of the value of low-dose CT screening for lung cancer. But even low-dose CT screening or the current status quo still has a lot of hurdles. So the CT scans are plagued with the issue of poor specificity. So when a nodule is detected by CT, there's still a relatively low chance that it represents a cancer. Here are two patients from my hospital, two different patients that had low-dose CT scans, screen-detected nodules, and the nodule here in the left upper lobe of this patient on the left side of the screen, in fact, did turn out to be an early stage cancer, whereas on the right side of the screen, the patient represented there with a looks like a right middle lobe mass, upon resection turned out to actually just be all scar tissue and inflammation. So this is certainly one of the biggest obstacles with low-dose CT scans. And then, of course, a separate societal issue is that we're really not doing the low-dose CT scans on all of the smokers for which they have been proven to be helpful in improving survival. But even if we were screening 100% of those patients who are eligible by smoking and age criteria for lung cancer screening, we would still only be catching a portion of patients who walk through our doors with advanced lung cancer. In fact, one group found that only about 30% of newly diagnosed lung cancer patients would have qualified to have been screened. Looking for blood-based tests, such as we're going to talk about today with ctDNA, can be tricky in lung cancer because, as we know from advanced cancer, the molecular profile of lung cancer is quite varied and heterogeneous, and there's not really one mutation that defines all lung cancers. If we had a liquid biopsy or ctDNA test, there are at least 4 different types of clinical applications that you could imagine it being used, and they all would require a different type of assay in terms of the sensitivity and specificity. So as we're developing these assays, we really need to think critically about what's their eventual clinical niche so that we can develop, design the tests in the right way. So for example, number 1, you could order a blood test prior to getting an LDCT. This is appealing in some ways because few people who should be getting LDCTs are, so maybe a positive test might encourage them to go get a chest CT. However, you wouldn't want the test to miss someone who had a cancer, so that's a high-risk type of situation. I personally think number 2 is quite appealing. After a nodule is detected on a CT scan, can you use a blood test to try and further risk stratify that nodule into worrisome for cancer or likely benign? A third potential use is after a nodule is detected on an incidental scan. Incidental pulmonary nodules in the general population is also a huge problem. The difference there is that most of them are not cancer. The vast majority are not cancer, but some of them are. So the specifications of a blood test for that application would be different. And you could also think about getting it prior to imaging the population. With a liquid biopsy, we're often looking for an all-in-one tool. We want it to be fast, sensitive, cheap, accurate. And of course, if you've ever bought one of these type of gadgets, which is pictured here, you know that usually they're not good at doing everything, and sometimes you need a different tool for each different field that you're trying to get. And of course, when we use the term liquid biopsy, remember that there are many different components of the blood that you can look at, including circulating tumor cells and exosomes. And my talk today is really more focusing on the DNA that is free-floating. Major pitfalls, which we won't be talking about in detail, but there are a lot of both technical, biologic, and clinical pitfalls that we have to think about when we're developing and testing these new technologies, summarized here. So circulating tumor DNA, or increasingly people use the term cfDNA for cell-free DNA, or circulating cell-free DNA. Remember that the difference is, so if we think of this as the pool of blood that has many different sources of DNA free-floating outside of cells, some of the DNA is contributed from tumor tissue. In this picture, it's a multicolored DNA. And there's, of course, healthy tissue that dies, and the disintegration of cells releases DNA from non-cancerous sources into the bloodstream. So cell-free DNA, it kind of represents the full panel of DNA in the blood, of which circulating tumor DNA is only a subset. We can identify circulating tumor DNA looking at the mutations, amplifications. We'll talk about some different research groups that have looked at methylation and other characteristics that might differentiate tumor DNA from healthy cell DNA. But for early detection, obviously we're all familiar with the great help in the clinic that some of these tests can be in trying to figure out if your patient has an EGFR mutation or an ALK translocation with advanced stage. But some hurdles specific to early detection is a tiny amount of tumor DNA which may be circulating in an early stage cancer, and the knowledge of which genes to assay. Looking at the differences, so knowing which genes to assay is one of the major differences between primary screening where you don't know if a cancer is there, and if it is, you don't have a sense of what the genotype of that cancer is, compared with looking at minimal residual disease after treatment of a patient with early stage disease and monitoring for relapse, which is a tumor-informed situation. You may have a surgically removed cancer. You can design a probe or a signature around the mutational profile of the cancer and then monitor for recurrence. That's almost an easier technical ask than early stage detection. And another important thing that is beyond the scope of this talk is the differences in the informatic approaches with these different assays. This looking at ctDNA generates a tremendous amount of data, and figuring out how to correct for errors, remove data which may be due to clonal hematopoiesis in the blood cells. These are all really difficult problems, and ultimately are going to be really important if one of these to the clinical arena. So next, I'm going to tell you briefly about several of the key papers that have looked at different technologic platforms over the last couple of years, trying to apply these platforms to early stage lung cancer detection. So the first to be published was TechSeq. This came out of the Hopkins group in 2017, and this technique is a discovery, next-gen sequencing, multiple parallel PCR discovery, looking for mutations in about 58 pre-specified genes that have to do with cancer biology. And they studied patients with 4 types of cancer: breast, lung, ovarian, and colorectal, as well as healthy controls. Here, on these scatter plots, you can see that compared to the healthy controls, which really didn't have any mutant allele fraction after they corrected for things like CHIP, patients with the various cancers did have detectable mutations, and also the mutations seem to go up in abundance with increasing stage of the cancer. And for a cohort of patients with colorectal cancer stage 1 through 3, preoperative detection of some of these mutations in red was a poorer prognosis in terms of both PFS and OS compared to other patients that had low or no detectable mutant allele fractions. So this in 2018, there was a lot of excitement about this Cancer-Seq paper, which also came out of Hopkins, slightly different group of investigators. This panel, Cancer-Seq, not only looked at mutations in ctDNA. They were looking at 61 different regions of interest and 16 pre-specified genes, but they also looked at 8 protein markers in the circulating in the blood. They tested a larger group of patients, just over 1,000 patients with 8 types of cancer, and then an additional 800 controls. And you can see that the proportion of cancer patients which had abnormalities detected by Cancer-Seq again varied from about 43% with stage 1 up to in the 70s with stage 2 and 3, and also varied depending on the type of cancer they had. Lung is here in the purple. About 58% of lung cancer patients that they studied had detectable mutation protein abnormality. They also tried to use their test, and this was mainly the protein portion of the assay, to see if they could guess the tumor of origin. Now, of course, all the subjects that they were studying, they already knew what the tumor of origin is, but they kind of took out that information, blinded themselves, used some machine learning, and tried to see if the pattern of protein signature and the machine learning could essentially back calculate what was the tissue of origin. And so here you see the top prediction in light blue that the machine learning algorithm cranked out, and one of the top two predictions. So for the lung patients, the top prediction was lung in 39%. And when you added in the 1 or 2 choice, it was 72%. There's a lot of interest in this tissue of origin type of analysis, and I'll show you as well that GRAIL is focusing on this. I mean, I think, again, these are for different types of clinical indications. So if you're going to take someone coming in for their annual history and physical with their primary care doctor and have a blood test to see if they have cancer, of course, then you're going to want a tissue of origin. That, you know, that kind of futuristic scenario, I think, is really attractive to some people. I think it's also, you know, practically speaking, it's a huge ask of a test to not only tell you if someone has cancer, but to tell you where it is so you can look. It's a, you know, different kind of assay if you're trying to figure out if a visible abnormality is cancerous or not. Things we need to think about as these assays are moved forward into the clinic, into trials. So later in 2018, we also saw this report from the Canadian group, CF-MEDIP-seq, which is really an assay looking at methylated DNA. So the pattern of methylation is different between tumor genome compared to the germline genome, and they're taking advantage of those differences in this assay. And the idea here is that you don't have to know the specific gene that is maybe activated or driving the tumor. Instead, you're just looking for a general epigenetic pattern of methylation. And this was a smaller study looking at 199 people, including 55 lung cancer patients and 62 controls. And for example, I've shown you here their ROC curves between early and late stage pancreas cancer and early and late stage lung cancer, and they look very impressive across all of these groups. So this was one of the first publications about methylation, and this idea has really caught on and is very hot in investigation. Delphi is a publication, a different technique that came out looking at another general feature of DNA, which is fragmentation. So again, not looking at specific mutations or driver events, but looking at a general category or a general classification of DNA that is different between cancer and healthy. So cancers tend to have increased variability in the length of the DNA fragments circulating, and you can see that on top, that the healthy control patients that they used had a relatively small variability in their fragment lengths of DNA across the different chromosomes, whereas the lung cancer patients, you can see the amplitude or the variation is much broader. And so this particular publication only included 12 lung cancer patients and about 200 controls. You know, with 12 patients, they actually reported 100% sensitivity and specificity with their assay. But again, this was a small group of patients, at least with lung cancer. Overall, this assay was also there have been a couple of presentations at major medical conferences, and just recently a publication on the GRAIL effort, which is in collaboration with a large NCI-funded program called the CCGA, or the Circulating Cell-Free Genome Atlas. The first presentation, which was at ASCO a couple of years ago, was really them looking at the difference between looking for ctDNA and methylation assays, and also proteomics. And by comparing, kind of doing a bake-off, they decided that they were going to focus going forward on methylation. And so at ESMO 2019, and then recently published, we've seen some of the work on a separate group of patients that were studied for methylation. And so here's the lung cancer slide that Dr. Oxner presented last fall, looking at about 261 lung cancer patients. These were compared to almost 900 healthy controls. And by looking at their methylation assay, you can see again in lung cancer, really great sensitivity for stage really 2, 3, and 4 patients, but the stage 1 patients, because their tumors are so small and the amount of ctDNA that they shed is quite low, the sensitivity was lower. It looks like maybe it's a bit better for squamous tumors than adenocarcinoma. And then this was recently published as well, kind of updated data from the same cohort, looking across all the different types of cancer that they studied. The pattern is similar as to what we saw previously in lung cancer, which is that it can be hard to detect stage 1 tumors. The larger, more advanced tumors are easier to detect. Some of those that did particularly well in stage 1 were pancreas in this cohort and head and neck. And then Grail is also working on a tissue of origin assay, which looks to be quite good, even in stage 1 patients who have detectable ctDNA, and figuring out what the source is. So this is something, that needs to be studied in patients moving forward, but certainly is exciting, especially if you're thinking about using it for someone without local symptoms or a localized finding. And then finally, the CLIP lung assay was just published in Nature. This is a research group that I'm a part of, a collaboration between Max Dean and Asha Lizaday at Stanford, who have developed the CAP-seq assay, and some clinical groups, including Stanford and MGH. This was part of a Stand Up to Cancer project that we did a couple of years ago. So essentially, this assay is using the CAP-seq, which is an ultrasensitive NGS-based ctDNA assay. There are a lot of really fancy technical innovations that Dr. Dean and Dr. Lizaday have put into this assay, especially when thinking about using it for screening where you're not informed by the tumor genomics. And I would say one of the main differences in our clinical work, which is still early, still relatively small numbers, but instead of using healthy controls, which is what all of the other studies did, people who are not known to have any specific diseases but are willing to donate blood. For lung cancer screening, we wanted to use high-risk controls, so patients who met the age and the smoking criteria to undergo low-dose CT screening and actually underwent screening and were known to have no significant nodules, so they had a negative CT scan. So we used high-risk controls, which I think is an important distinction, especially if you're using it to look at a known nodule and try and figure out if it's cancerous or not. So with this method with LungClip, again, the sensitivity is better for stage 2 and 3 disease. This is a training cohort, and then here's a validation cohort with a second round of training and then a final validation. So, we did try and enrich our cohort for stage 1 disease, because that's really where this is the most important, and for stage 1A tumors that are very small and non-invasive. In some cases, this assay had more trouble, but stage 1B, 2, and 3, it performed better. Again, as has been seen by some of the other assays, and also looking at minimal residual disease patients with the CAP-seq method, having detectable ctDNA was a worse prognostic factor than not having it. And these are all stage 1 lung cancer patients, but looking at PFS and OS. So we're looking forward to studying this assay more and actually bringing in a methylation component to the assay. So in summary, where do we stand today? I'm sure there are also some other publications. I tried to touch on some of the ones that have gotten the most buzz, but there are literally dozens of innovative technologies and techniques that inventors and engineers and scientists all over the world are developing. Many of these studies use healthy controls who may not have been assessed for whether or not they have the cancer that you're studying. And I think, again, careful thought as we move these assays into the clinic is required in terms of picking the correct controls for your clinical situation. High-risk patients may be a better baseline for some situations. Detection of stage 1 disease has been a hurdle universally across all of these platforms, and prospective trials testing how we actually integrate these assays into our clinical practice, I think, is going to be really important, and that's one thing that not a lot has been published about. ASCO published a position paper in 2018 about ctDNA assays, essentially saying that they had no clinical role in screening early detection at the current time, and I believe that that still stands with our current data. These assays need to be tested prospectively in patient populations before they should be unleashed onto the public. And with that, I think my time is up. I'd like to thank the MGH Stanford Stand Up to Cancer team that worked on the CLIP lung paper. Our team, part of our team is pictured here, and also my dog, who really has helped me and my husband and my kids get through the pandemic with our sanity mostly intact so far. Thank you for your attention, and thank you for having me here.
Tell our team, try to be a level. These are my disclosures. So currently, after smoking cessation, the most effective intervention for lung cancer treatment is early detection through low-dose computed tomography. This assumption is based on the results of 3 major trials: the USA NLC trial, a large-size trial using 3 rounds of screen and comparing low-dose CT versus chest X-ray, showed a significant mortality reduction of 20% already in 2011. These results were later confirmed by the Nelson trial, published in 2019, a medium-sized trial that used 4 rounds of screening over 6.5 years, which confirmed the benefit of screening by low-dose CT by a reduction of 26% in lung cancer mortality, a rate that was even higher in the female group. Finally, the Italian MIL trial, a small-site trial, provided additional evidence that extended screening beyond 5 years with annual or biannual rounds of screening increases the benefit of screening by showing a reduction of 39%. Nonetheless, the development of blood-based biomarkers, non-invasive biomarkers, could be very helpful to increase the performance of screening in at least 3 major areas: to better predict lung cancer risk, to personalize LDCT screening intervals, and importantly, to resolve those indeterminate suspicious nodules identified by LDCT, therefore to potentially decrease false positive rates and lead to a reduction of subjects needed to be followed. Why microRNAs? We started already 20 years ago in this institution in collaboration with the team of Ugo Pastorino, who runs these screening trials, and we first published, well before the era of liquid biopsy, the presence of ctDNA, tumor DNA, in blood of lung cancer patients with quite good diagnostic value in form of tumor mutations, DNA mutations, methylation, or microsatellite instability. However, when we moved these biomarkers in the context of screening, they were not useful to detect the very early cancer, screen-detected cancer, probably also for the technologies employed at that time. So the reason of our choice to using other kind of molecules was that we were more interested to look at changes not only dictated by the tumor, but also from the host. And microRNAs are released not only from tumor cells, but also from the stromal lung microenvironment and immune cells. Therefore, they may better reflect changes of the tumor-host interaction. And probably they can represent a very early response of the host to an incipient tumor growth. MicroRNA, as probably all of you know, are small non-coding molecules with a regulatory function that circulate in blood, protected in extracellular vesicles, such as exosomes, or bound into ribonucleoprotein complexes that protect them from degradation, and therefore they remain rather intact in biological fluids. They are also the advantage of being quite easily detectable by simple techniques such as real-time or digital PCR that are also suitable in a clinical laboratory. We started our preliminary studies that are already published in 2011 by profiling microRNA in plasma of subjects enrolled in a LDCT screening trial, a pilot trial, where we demonstrated that 24 microRNAs were able to compose diagnostic and prognostic signature able to discriminate lung cancers identified in the screenings versus heavy smokers without cancer. We used technologies based on microfluidic cards starting from over 400 of microRNAs. For the validation study, we generated a three-level risk classifier by combining the different signatures in a unique classifier that we called MSC, with three levels of risk, low, intermediate, and high. And we validated this MSC test in a large cohort of 1,000 smokers enrolled in the MILD trial, with 85 subjects developing lung cancer within 5 years. MSC show a good sensitivity, 87%, 81% specificity, and in particular, it was able to predict lung cancer risk development up to 2 years before the burden of the disease was clearly diagnosed by LDCT. So, based on these promising results, in 2013, we launched a prospective trial called BioMILD, that was based on the following biological hypothesis. We hypothesized that lung cancer risk is not homogeneous across age and smoking, but is determined by an individual lung damage. We also posit that the individual risk is predictable by combining low-dose CT, so a radiomic feature, with a blood biomarker, and hypothesized that personalized prevention could be possible. We sent, in the study design of BioMILD, we sent to 3 years those subjects having an LDCT negative finding and a Myrna low-risk profile. We sent to 1 year those subjects with an indeterminate nodule identified by LDCT or an intermediate Myrna risk profile. And we sent to shorter time interval, 3-6 months, those subjects having either a positive nodule or a high-risk Myrna profile. Interestingly, already in 2013, we set a higher cutoff for nodule size, solid nodule size, that were optimized on the basis of the MILD trial experience. And we were surprised to look at the guidelines released in LAGRADS 2019, because the cutoff we choose were absolutely similar and mirror very clearly those present in the LAGRADS guidelines. So the specific aims of the trial were therefore to evaluate the utility of combining Myrna and LDCT to predict individual lung cancer risk, assessing the feasibility of longer screening intervals in negative subjects, double negative subjects with negative LDCT and negative risk profile by Myrnas, and reveal potential damage of sending subjects to 3 years interval in terms of proportion of stage 1, resection rates, or interval cancer. And finally, and importantly, to assess the incremental value of using Myrna assay, blood Myrna assay, in indeterminate and positive LDCT identified lesions. We registered over 9,700 subjects and ended up with 4,119 enrolled individuals who underwent low-dose CT, blood collection, Myrna profiling, spirometry, and monoxide evaluation. At baseline, 58% of the subjects were classified as double negatives, 37% as single positive, either one of the 2 assay positive, and 5% were the double positive, with both assay positive at baseline. Volunteers' baseline characteristics across the 3 risk profile are shown here. The three risk levels didn't show any differences in the proportion of males, age, PAC years, current smokers, or NST eligibles criteria. And here are the preliminary results. At 4 years follow-up, median 4 years follow-up, with all the subjects having reached the at least 3 years follow-up. We identified 115 lung cancers, accounting for 2.8%, and noticed a quite significant differences in the incidence of lung cancer in the 2 positive groups compared to the single or the 2 negative groups. Similar results for lung cancer mortality, with a significant difference in mortality in the double positive category compared to the other 2 groups, whereas we didn't observe any increase in the number of interval cancers. Looking at the lung cancer developed within 3 years, which was the time where we sent the double negative subject, only 3 subjects developed lung cancer, whereas the double positive subject showed a significantly higher incidence in lung cancer incidence. No significant differences in the number of stage 1 or in the proportion or resected cancer or in the histology distribution were detected. And interestingly, only 3 patients underwent resection for benign disease, accounting for a rate of 4.2%, a rate which is well below the threshold of 10% recommended by guidelines and the best rate for benign resection published so far in screening trial. Lung cancer cumulative incidence curve showed a significant differences in the double positive group compared to 1 positive and 2 negatives, with an adjusted hazard ratio corresponding to 36.64 in the double positive group. Cumulative lung cancer mortality also was highly significant, with a higher mortality in lung cancer in a double positive category and an adjusted hazard ratio of 32.24. We then look at the value of the Microrna test alone within each LDCT subset. The best results were obtained in the subgroup of LDCT indeterminate and positive lesion together, where subjects with a Microrna positive test showed a quite significant difference in cumulative lung cancer incidence compared to the Microrna negatives. Nonetheless, also in the subgroup of LDCT negatives subject at your right, Microrna, the results were significant. Microrna positive subject had a cumulative incidence of lung cancer higher than Microrna negatives. However, the 4 of the 5 Microrna positive subjects identified in this LDCT negative group were small cell lung cancer, and therefore with a quite worse prognosis. So the clinical benefit of using the Microrna assay in this category remains to be questionable. So preliminary messages of the BioMil trial is the first prospective screening trial testing low-dose CT and Microrna biomarkers, which showed a significant clinical utility. The combination of the 2 assays allows an optimal screening intensity and reduces unnecessary LDCT repeats. The knowledge of individual biologic risk by Microrna and LDCT seems to improve the efficacy of screening and should guide future preventive strategies. So we can now say that personalized prevention is a real option. However, since we are scientists, we are not only interested in clinical studies, but also we were interested to understand the origin of the Microrna composing the classifier. And to this purpose, we performed an expression analysis of our 24 Micrornas in cells and in the released conditioned medium of several cell types, not only lung cancer cell lines, but also normal bronchial epithelial cells, stromal fibroblasts isolated from our patients, endothelial cells, other stromal components, and immune cells. we notice that indeed the major releasers and expressors and releasers of our 24 Myrnas were hematopoietic cell lineages. And these results were confirmed by an in situ hybridization approach that we developed in a collaboration with the team of Claudio Tripodo in Palermo, where we showed that clearly several of our Myrnas were highly expressed in the hematopoietic lineages. In addition, we treated with several different drugs our cell lines in order to induce a transition toward a protumorigenic or immunosuppressive phenotype and look at the modulation of our Myrnas during this transition. Interestingly, we noticed that the specific Myrna composing the signatures were modulated in the process of acquiring a protumorigenic or an immunosuppressive phenotype. So, given this observation of this origin of our Myrna from immune cells, we decided to characterize circulating immune population by multiparametric flow cytometry in PBMC from the BioMil trial patients. This was done in collaboration with the team of Liccia Rivoltini in these institutions. We try also to correlate these immune subsets with an MSC high-risk risk profile. Interestingly, we noticed that MSC high-risk subjects were at an enriched circulating hyper-exhausted T-cell population, which was significantly higher compared to the MSC in the intermediate and low risk, whereas the NKT cells, which are protective elements inducing ADCC, were clearly and significantly reduced in this class of risk. So this observation further support a strict association between MSC and an immunosuppressive phenotype. And the further proof of this came from our analysis of a tumor immune contexture in tumor tissues from 37 frozen sample of screen-detected patients, where we noticed, as shown in this radar plot, that an MSC high-risk profile reflected a cold immunophenotype characterized by an increase in immunosuppressive T regulatory or T gamma cells, gamma delta or M2 macrophages, and a decrease in T cell cytotoxic or NK effector cells. And based on this observation, we decided to look at if the MSC assay could be useful also in an immunotherapy context. And we took advantage of the patients enrolled in the Apollo study, which is run in this institution by Marina Garassino and her team. We look at 118 patients characterized in plasma MSC profile, and look at patient survival according to MSC risk profile. Indeed, a lower 1-year progression-free survival was observed in MSC high-risk patients compared to in the intermediate or low-risk patients, as shown on your left. And these results were confirmed also in the overall survival analysis. Take-home message. BioMil is the first prospective trial combining a blood biomarker and low-dose CT. We have now reached the 5 years follow-up required by everybody, so we are reanalyzing data and the publication is in progress. Circulating Myrnas seems to have a clear clinical utility in screening trials to implement LDCT findings, not alone, but to implement LDCT findings. We have now evidence that MSC risk associated with an immunosuppressed systemic immunity that could predispose to lung carcinogenesis, and which explains the good results of using this assay. And finally, the knowledge of individual biologic risk by Myrna and low-dose CT seems to improve the efficacy of screening and should guide future preventive strategies. And we have an Horizon 2020 European project ongoing with the Dutch people, where we hope to further validate this finding.
wish to thank the collaborators of the study, my unit, the tumor genomic units, particularly Mattia and Orazio, who ran all the MSc analysis. Ugo Pastorino and his staff, the BioMild and Mill Bio staff of the thoracic surgery, the medical oncologist, thoracic medical oncologist, and Marina Garassino in particular, and the anatomical pathologist of this institution and of University of Palermo. Thank you to you all for your attention.
Thank you very much, Dr. Sozzi, for your great talk. Are there any questions from the audience? If there are no questions, I have some questions for Professor Carbone. Okay. Are there any data about the problems about the surgical approaches after a neoadjuvant treatment with immunotherapy or a combo of chemotherapy plus immunotherapy? Are there some issues from a surgical point of view? And the second question, the two phase 2 studies, NeoStar and LCMC3, did not confirm the major pathological response rates achieved by nivolumab in the first paper published by Ford and colleagues in 2018. Considering that the combination of chemotherapy plus immunotherapy can achieve major pathological response rates up to 80%, and that we are in a curative setting, do you think that there is still a role for immunotherapy as single agent as a neoadjuvant treatment? Thank you.
Okay, so it's a very good question about whether the neoadjuvant immunotherapy interferes with surgery, and I think there is a impression that there is potentially more inflammation observed at the time of surgery. But if you look carefully at our data, and we actually are presenting a surgery-focused abstract at World Lung as well, really there are no differences in the surgical outcomes, no difference in the conversion from minimally invasive to open surgeries, and no difference in the number of patients that are found to be unresectable at the time of surgery. So I think that that's not not showing to be a major concern. Now, your point about the mycologic response rates is a good one, but just like in treatment of advanced disease, I mean, we do have a subset of patients that may not need chemotherapy. I have patients in my clinic that treated with IO monotherapy who have been off therapy for years and never had chemotherapy. So if we had a really good biomarker for that subset that didn't need chemotherapy, then I think we could avoid it in some patients. However, I think it is reasonable for the initial studies to use a combination since the objective response rates are so high.
Thank you very much.
I have a question for Professor Herbst about Audera trial. In fact, 70% of patients, they had the stage 2 and 3, but only 55% of them, they received adjuvant chemotherapy. So there was around 15% of patients that did not receive adjuvant chemotherapy. And I was wondering if this percentage of patients can impact on the final disease-free survival results. And also if the administration of adjuvant chemotherapy should have been considered as a stratification factor within the stage 2 and 3.
Thank you. Can you hear me?
Yeah.
Yeah, I don't know if my image is moving, but I'm here. Yeah, it was a worldwide trial. And, chemotherapy, of course, is usually given in stage 2 and 3. More than 80% of patients receive chemotherapy in each of those settings. Why did they not all receive? We don't know that. We don't have those data yet. I'm not sure if we will. We'll try to get them. But, it was both patient and physician decision. might be some of the patients, weren't felt to be candidates, though all patients were 0 and 1 performance status. So that most likely wasn't the case. Did some people feel they would just go to EGFR therapy alone? Maybe they knew in advance that the patients were EGFR mutated. We don't know, but the bottom line is most of them did. The bottom line is that the randomization occurred and the results were consistent in both groups. But one question I think people are going to ask in the future is, in some of these patients, do you even need the chemotherapy? And of course, we already saw from Benjamin, we already saw the CTONG trial, but should that be repeated perhaps in some settings with osimertinib? But hard to say exactly. We'll try to get more information on that. But most of the patients that did not receive the chemo were in the stage 1B.
Okay, thank you.
I have a question for Professor Bess. It's a difficult question, Professor Bess. I'm sorry about this. Tomorrow, from a regulatory point of view, you could give your patients osimertinib as adjuvant treatment. Will you give the drug or not? And if not, would you accept the risk to avoid your patient a potential effective treatment only because of the missing data about overall survival, since we will have to wait for years to achieve them? Thanks.
If tomorrow the drug is approved based on DFS without any additional OS data, yes, I will prescribe osimertinib, because DFS is an accepted endpoint. And while we have led with ETOP at EORTC the PEARLS trial that tested adjuvant pembrolizumab, and DFS is the primary endpoint. So for all the adjuvant trial today, DFS is accepted, and there will be probably an approval for osimertinib. But I will be very careful of the overall survival data, and if at one point the overall survival data come with no benefit, well, there I will probably discuss with the new patients on the immediate versus delay benefit. One important point, I think, is that we should not switch from chemo to OSI, because ADAURA is a post-chemo trial. So even if half of the patient did not receive chemo, still chemo increased the overall survival. And we have seen in the metastatic setting that chemo plus TKI might induce an additional benefit compared to TKI. So I think that we should still do the best we can for the patient, so not switch to the easy one that is 2 years of osimertinib, but still start with 4 cycles of adjuvant chemotherapy and then move to osimertinib as the ADAURA trial was designed.
Thank you very much.
I have a question for Dr. Sozzi. Microrna are a very interesting biomarker also in advanced setting. I just don't know if they are just a phenotype of something that is happening. I mean, they are a phenotype of a tumor that is becoming resistant to immunotherapy, or they may have a direct role, a mechanistic role in driving tumor resistance to treatment, or also tumor that comes back from surgery or from other localized treatment.
Well, there are several studies, including some papers published by our team, showing that Micrornas have a functional role. So circulating Micrornas seems to communicate information from the tumor to the other cells of the microenvironment and of the host. So they can have a functional role, not only to be biomarkers of the disease or of the response. In fact, several studies have shown that inside microvesicle, Micrornas can transfer information and also modify the phenotype of recipient cells. if we have used several of our Micrornas in recipient cells and look at the change in phenotype, and indeed we see major changes by treating cells with Micrornas. So I strongly believe that they could have a functional role in modifying recipient cells, and therefore they can be useful to show a response also to treatment, or be functional.
Okay, thank you very much.
Okay, we are perfectly on time. Thank you very much to all the speakers for their wonderful presentations, and to all the audience. And let's move to the next part of the day with the cocktail show. Okay.
Hello again. So this is the time for our cocktail. So you have to take the box with M, and we can have a look to the video with Valentina and Lorenzo again, and then we will toast together. Today we will not go to Zoom, so stay here and we will celebrate here.
And now, welcome back. Ciao a tutti da Lorenzo e Valentina.
Valentina, hi.
Welcome back. Hope you guys enjoyed the yesterday aperitivo. Today we're back with a new recipe, new cocktail recipe, but still new food recipes that you will prepare again in your home, in your houses.
But today we are, with the ingredients, we are in Europe, not only Italy, but in Europe.
Yeah, today we go farther north. We came up to the colder part of Europe. We use ingredients like
Fresh salmon.
fresh salmon,
Then green apple.
green apple, wonderful,
Shallot.
shallot,
Lemon.
lemon,
Blueberry.
blueberries, oh wonderful,
And chive.
chives,
Chives.
chives,
Erba cipollina.
erba cipollina, we don't know, we're Italian, we don't care. So, today as well, I will prepare a cocktail that is inspired by the ingredients that Valentina will make in a wonderful aperitivo. And let's start. Let's get started. So, Valentina, show us.
Okay, let's go. Let's put the gloves on because we are using the fresh salmon. Otherwise, if you don't want your hands to smell like fish for all day, you just can use gloves.
Odore di pesce.
Odore di pesce, no good for hands, for society. Okay, take the salmon.
Okay.
And just cut before into slices.
Okay, so you do it in the slices before?
Yes.
Okay, wonderful.
And then small cubes. We don't want a smashed up salmon, but we want little cubes.
Okay.
Okay.
So be very careful with the knife because otherwise you can cut yourself.
Yes, I'm very
Valentina is very skilled, so it doesn't happen so much. So
very concentrate.
Okay. So you go all around and you do it like in squares.
Yes, we need cubes, not smashed up, but cubes. Okay.
Not just like a tartar, but like
it's a tartar, but with thick cubes.
Okay, so big cubes.
Big cubes, okay.
Okay. So that's ready. That was fast, pretty fast.
Yes, almost done.
Okay. And the fish is ready.
Okay, the fish is ready. Let's take gloves
off. Wonderful. Clean the knives.
Oops.
Okay.
Let's clean everything very, very well.
Remember to clean thoroughly everything because cleanness is
especially when you use fish. So we have cubes of salmon, then take a green apple and cut into cubes the same dimension of the salmon.
Roughly.
Più o meno.
Più o meno, more or less, you know,
yes,
remember.
More or less. And just put them together.
Okay, so I put it into the bowl?
Yes.
Okay.
Mix it up.
Okay.
I like very much the colors of this tartare because I like orange and green colors. It's going to be very, very good with your ginger and blueberry. The color will mix very, very well.
Yeah, exceptionally because the color of the ginger, you can spot it from here, is blue and yellow as well. So there are two complementary colors, if I'm not wrong. So the shallot is coming.
Yes, very little pieces.
Again, be careful with the knife.
This one has to be thin.
Okay.
Yes, otherwise if you find a big piece in your mouth, it's not going to be very, very
pleasant.
Good.
Yeah, you know, piacevole.
Especially for the person you're eating with.
But if the person is eating with you the same thing, not a problem, no? No?
Okay.
So no kisses for you, niente più baci, mi dispiace. Okay, so the shallot is ready, so you're gonna put it inside of the bowl as well?
Yes.
Okay. I'm getting through it. I'm gonna understand.
You can take the quantity you want. If you like it or if you don't, you can take the quantity you want. I like it, and so I put a little bit of quantity.
Okay. So a little bit, almost all of the shallot.
Okay.
Okay. So the smell is really amazing right now, as well at the moment. So, and it's not even ready as well. So.
The last one, last ingredient.
Almost done. Already?
Yes, it's very, very quick
very
and
easy. Very fast. Wonderful.
And you can do it while you wait for your cocktail to be fresh and good enough.
Yeah, while it's chilling up. Yeah.
You can prepare it.
I said here.
Then you take this.
Erba cipollina.
We decided how it's called in English? No.
No.
Okay.
We don't care.
It's not very important. Okay.
Okay, slice it thoroughly.
Cut it.
Yeah. She's a master with a knife, you know.
No, I'm not. I really am not.
Okay.
Okay. Let's put a little bit, not too much. Okay. And then take a lemon. And this one, this is very hard to know.
Grattugia, to grate, you know. As well, we're Italian, we don't care.
It's a typical English verb, to grate. Okay.
So just the yellow bit, you know?
Yes, just don't take the white.
The white, because it becomes bitter. Yeah. Okay. What a perfume! I can smell it from here. It's wonderful. It's wonderful. Meraviglioso.
Okay.
Okay. So everything you need. Okay.
We're almost done.
Almost done.
Almost done. And now let's add some salt.
Okay.
Salt.
So today, as you can see, we're not insisting for Italian ingredients, unless it's oil. You know, we're very proud of our products, and oil as well, extravergine. You gotta use it. Dovete averlo.
Yeah.
Sorry. It's the only Italian ingredient, so.
I'm gonna use today a red pepper because I like the color, and it's a little more delicate.
Yeah, not so intense as the black one.
Yeah.
Okay.
Let's take it in your hand and let's.
And crush it.
Yes, with your fingers.
So it's not so hard to crack it like the black one.
It's soft, and I like to smash it with fingers.
And the color is wonderful as well.
Yes, it will give it just a little bit of red color. Okay, we are ready for the final
ingredient.
For the final preparation of the dish. I like the black dish because for the colors I chose this one. And this is a ring.
In Italian it is coppa pasta. I don't know exactly why, because I don't know if you can make any pasta inside it, but its name is
It's
coppa
also
pasta.
called the ring.
The ring.
The ring.
Like the Lord of the Ring.
Like the movie, The Ring.
No, I said otherwise.
Okay.
So you put it inside and then you press it?
Yes.
Okay.
You can easily do it without. It's very easy to do.
But like this, you know.
Because I am a chef, and so I have to do it with a ring.
Chef things.
Of course.
Okay. The smell is fabulous.
Okay. I don't like to push it too much, just a little bit, okay? And then something like this, okay. Okay. And now let's finish with some green.
The garnish.
Yes.
Wow.
Some finocchietto.
Finocchietto. Fennel. Fennel. Fresh fennel.
Fennel. And some blueberry to match with your cocktail that I'm very curious to drink later. Okay.
That's really nice.
And final oil.
A little of olive oil. Wonderful.
Okay.
So I don't know if I will be able to match with your masterpiece, but I will try my best, Valentina.
Okay, Lorenzo, now it's your turn. What are you gonna make to me?
Okay, to match your wonderful masterpiece, I will choose between our great collection of cocktail ready to drink. The cocktail M for you today as well matches the blueberry, and we added a little bit of vodka and lime juice to cleanse your tongue off of the fatness of the fish, and as well with some ginger. So,
great.
This is the cocktail that we chose for you, and today we're gonna use something special to put in inside of a glass. This is our glass, and this is gonna be our ice cube. So, because of the bigness and the boldness of the ice, we're gonna use a little bit of personalization, because we like to do the cocktail in our way. So, it's very peculiar. So, you can spot our brand carved inside of the ice block. So it's a kind of way of a personalization of the drink. We did it our way. So the ice as well is our way. So
very good.
Thank you, Valentina. So we put it inside carefully of the glass. So as well with the cocktail that we're gonna pour. So remove the cap. And as I said before, the cocktail is ready to drink, so yet diluted. We just need to chill it out. So we're gonna pour it over the ice.
Very good color. I like the color.
It's made because of the blueberry. So
perfect.
With a little bar spoon.
It's really well matched with the colors of the salmon fish.
Yeah, it reminds me as well. So I think I'm gonna put another block of ice, because ice is never enough.
Wow, this is a big piece of ice.
You're not gonna be intimidated by the volume of the ice, because ice does two things: dilutes the cocktail and chill it up. So it's gonna be fresh, it's gonna be gorgeous, it's gonna be marvelous. So
great.
You don't have to be ashamed of putting ice inside of a cocktail. It's good for you, it's good for the drink. So now about the garnish. So we're gonna put on some blueberries as well, like Valentina did in our
on my
dish. Yeah, and a little bit of fresh ginger to match the nose of the cocktail. Maybe a little bit more.
It's great. I like it.
Try to make it gorgeous. And another blueberry. So the cocktail is ready. The food is ready.
The food is ready.
Enjoy your aperitivo and salute.
Okay.
E alla prossima.
Have fun with our aperitivo.
So hello again. We want to celebrate with you this moment. So take the M and so cheers. Thank you so much for your participation.
Cheers.
Hello again. The pandemic started here in Milano in the end of February, and we realized immediately that it was a crucial moment for the life of ourselves and also for the life of our patients. So I sent an email, a very famous email, in the middle of March to all my friends, also many people here today. And Liora Horn replied and said that she could create a database to collect all the patients with thoracic malignancies and COVID. And after that, more than 220 centers joined the effort. The most relevant scientific societies, and I say ESMO, ISCLC, ERC, ETOP, decided to support our effort. And now we have collected more than 1,000 patients. So I want to dedicate this lecture to my friend, Liora Horn, and I would like also to acknowledge all the people here who decided to join TeraVolt, and I'm happy to leave the word to Liora for the presentation of COVID-19 and thoracic cancer, and I really hope to see her and to see all the friends, and not just virtually, and to do an aperitivo together in Milano in person. Thank you for your attention, and Liora, please.
Thank you, Marina, for having me here today. And I'm really looking forward to having a cocktail with you in person one day, because it means that this pandemic is finally under control worldwide. And so I'm going to be talking about COVID and thoracic cancers. These are my conflicts. So as many of you know, the first reports of COVID-19 came out of China, and one of the large cohort studies that emerged from Hubei province included 105 patients with cancer and 536 patients who did not have cancer. All of these patients were hospitalized for COVID-19. And what the initial data reported was that the rate of death, ICU admission, severe critical illness, or invasive ventilation was much higher in patients with cancer compared to those patients who did not have cancer. And the proportion of patients with severe events by time was also significantly higher in those patients who had a cancer diagnosis compared to those who did not. We were worried particularly about our patients with thoracic malignancies, as reports were also emerging around that time from China that patients with thoracic malignancies were particularly at risk for severe complications from COVID-19. So here is our patient that we're going to see today in clinic and next month as this pandemic continues. We have a 68-year-old male, a former smoker, with a new diagnosis of non-small cell lung cancer with metastatic disease to the lung, the lymph nodes, and liver. His tumor is adenocarcinoma histology, his genetics is pan mutation negative, and his PD-L1 score is 30%. We talked to him that his preferred therapy for his disease is chemotherapy with a checkpoint inhibitor. He wants to have the best therapy, but is concerned about COVID-19 and coming in for care. And so should we be altering our treatment in our patients during this time? COVID presents for us in thoracic cancer as a clinical dilemma. The common presenting symptoms are often dyspnea, cough, fever, anosmia, and fatigue. And unfortunately, we know these are also common presenting symptoms in cancer patients. It also presents to us a radiographic dilemma, and I stole these slides from Dr. Garasino. On the left-hand side, we see a patient who has immunotherapy pneumonitis, and on the right-hand side, we see a patient with SARS-CoV-2 pneumonitis. The two are readily indistinguishable to a radiologist, and sometimes even in clinic, it's been difficult to distinguish the two. Now, there have been multiple reports that have come out looking at lung cancer and other tumor types. One of the largest reports was published by Dr. Tien that included over 13,000 patients with COVID-19 and 232 had cancer. On the right-hand side, we can see the different tumor types, and we can see that our lung cancer patients comprised about 9.9% of patients that were included in this cohort. They looked at what was some of the factors in these patients, all patients compared to patients with cancer and without. We can see that these patients were similar when it came to their age, their gender, the incidence of comorbidities, including hypertension, diabetes, and cardiovascular, as well as renal disease. What was different, however, with these patients' outcome? We found that in the patients who had cancer, the COVID-19 severity was much higher at 64% compared to only 32% in those patients without cancer. We also found that the mortality was almost doubled at 20% in patients with cancer compared to 11% in those patients who did not have cancer. When we looked at factors associated with severe COVID-19, older age, a worse performance status, more advanced stage disease, and those patients who were more likely to have received chemotherapy, radiation therapy, target therapy, or immunotherapy but not surgery, were all at risk for a more severe COVID-19 course. In addition, they found patients who had chemotherapy within the last 2 weeks and were also less than 1 year since their cancer diagnosis were also at higher risk compared to those patients who were greater than 1 year or even those patients who were 5 years out or longer. When they looked at some of the laboratory correlates associated with worse outcomes, they found that higher levels of TNF-alpha, lower CD4 levels, higher levels of BNP, and the albumin-globulin ratio were all predictors of a more severe outcome in these patients with malignancies, but not necessarily restricted to those patients with thoracic malignancies. The next data set that we saw was in COVID-19 in a large hospital system. This was out of the US, where they looked at 946 COVID cases. Approximately 1/3 of those cancer patients were hospitalized, less than 10% of those patients were admitted to the ICU, and less than 10% of those patients died as a result of their illness. When they looked at some of the predictors of severe respiratory illness, they found that age over 65, as well as immune checkpoint inhibitor, were potentially associated with a more severe COVID respiratory illness. While there was no clear impact on gender, race, comorbidities, cancer stage, surgery, and diabetes, chemotherapy, or use of corticosteroids. When they looked at an immune checkpoint inhibitor use, looking at lung cancer patients versus those patients who did not have lung cancer, they found that unfortunately our lung cancer patients were more likely to be hospitalized, 52% compared to 38% in other solid tumors, were more likely to have a severe respiratory illness, 35% compared to 15% if they did not have a checkpoint inhibitor. And if they had a checkpoint inhibitor, it was even worse, 83% compared to 47% in terms of hospitalization, and 58% compared to 26% in terms of severe respiratory illness. In a smaller hospital system from Montefiore, they looked at 218 COVID-19 positive patients. 28% of those patients died, and they found that unfortunately in those patients that had died, 37% had hematological malignancies, and the death rate in lung cancer patients was 55%. In multivariate analysis, when they looked at the risk factors associated with death, they found that once again, age appeared to play a role. Those patients who were admitted to the ICU, some laboratory factors including D-dimers and lactate and LDH, as well as their Charlson comorbidity score. However, gender did not play a role in this cohort of patients. And so the UK Coronavirus Cancer Project tried to also look at an entire country and looked at what were their outcomes in cancer patients with COVID-19. What they looked at was 100 patients who had cancer, but important to realize that these patients were symptomatic. Of these patients, 88% required a hospitalization, 52% were classified as having a mild COVID-19 course, and once again, only 7% of these cancer patients were admitted to the ICU, and 28% of those patients died. When they looked at some of the factors that were associated with death, they found that shortness of breath on presentation, older age, male gender, and comorbidities including cardiovascular disease and hypertension were associated with death. After they adjusted for age, gender, and these comorbidities, only chemotherapy in 4 weeks had no significant effect on mortality from COVID-19. What they also found, which was striking, was that 22% of patients were reported by sites as having their anti-cancer treatments interrupted because of the pandemic. This is something that we constantly think about and worry about in our thoracic cancer patients. Last year, the American Cancer Society statistics came out with improved cancer mortality, and some of that was attributed to improvements in lung cancer mortality because of better treatments and better screening. And now are we going to take a step backward in the next few years as we have more deaths associated to delays in screening and delays in care for our cancer patients? This is some of the data showing the relationship of chemotherapy within 4 weeks of infection, again, showing that chemotherapy in this cohort of patients was not necessarily associated with a worse severity of disease or disease outcome. So we needed better data on lung cancer, and as Dr. Garasino mentioned earlier, she sent out an email to many of us at the beginning of this pandemic when Milan was particularly hard hit by the COVID-19. She was worried about the outcomes in our thoracic cancer patients and said that we need to start collecting data so that we can help people figure out how do we manage our patients during this pandemic. Within 1 week, we had a REDCap case report form, we had a final protocol approved, and we had IRB approval here at Vanderbilt University Medical Center, and Dr. Garasino managed to get approval for the whole of Italy. We started off with just 14 countries that had signed on to our database. By the time of data in May of 2018, we had 24 countries and 233 patients with complete data, and we had 24 countries and 400 patients with complete data entry. At this point, we're up to 28 countries and 130 cancer centers and almost 1,200 patients who have data entered in the complete form in our case report forms. What we found was that we divided our patients into 3 groups. We divided them based on those patients who had recovered from their COVID-19, those patients who had died as a result of COVID-19, and those patients with an ongoing infection. What we can see in those patients who had died, their age was slightly higher at 70. 70% of those patients were, of the patients who died were male. There were slightly more current smokers and former smokers in those patients who had died, a higher number of patients who had a worse performance status, and a high number of patients on ACE inhibitors, ARBs, anticoagulation, and steroid equivalent of 10 milligrams or more of prednisone. It's important to remember when you look at our data compared to other data that we had eligibility that required either patients have a positive COVID-19 diagnosis on RT-PCR, or they have combined radiographic and clinical findings, which here we classify as radiographic findings, or they have clinical findings with a known positive 19 COVID contact. When we looked at the most frequent comorbidities in our cancer patients, we find that in those patients who had died on the right-hand side, only 9% of those patients had no comorbidities, compared to 18% of patients who had recovered. When we look at the most frequent comorbidities, we found that hypertension, COPD, vascular disease, diabetes, and renal insufficiency were the most common comorbidities in our patients. When we looked at their cancer therapy within the last 3 months, it was striking to see that regardless if those patients had recovered, died, or had an ongoing infection, almost 70% of these patients either had no treatment or were in their first line of therapy. Again, coming back to that point that we know that we've made significant advances in treatments of patients with thoracic malignancies, and are these patients who are dying as a result of COVID-19 before they even have the chance to see the benefit of their cancer therapy. When we look at the types of therapies that were administered, we can see in the patients who died that approximately 45% of those patients were on chemotherapy. Immunotherapy was also common, as well as targeted therapy, radiation therapy, and other may have included such things as surgery. When we look at factors that were associated with survival, we found that age over 65, the presence of any comorbidity but not one specific comorbidity, an ECOG performance status of 1 or more, steroids of greater than 10 milligram of prednisone equivalent a day, current anticoagulation at the time of COVID-19 diagnosis, not to treat the COVID-19, and cancer therapy in the last 3 months, specifically chemotherapy alone or in combination with other therapy, were all associated with an increased risk of death from COVID-19. In our analysis of impact on therapies administered to treat COVID-19, we found that there was no specific therapy either in those patients who recovered or those patients who died that was associated with worse mortality from COVID-19. I highlight this as CCC19 found that hydroxychloroquine in combination with any other agent was associated with an increased mortality in all cancer patients, regardless of their histology. When we looked in the multivariate analysis at risk of factors associated with death from COVID-19, we found those patients age over 65 years old, an ECOG performance status of 1, steroids prior to COVID-19 diagnosis, and chemotherapy with any other therapy were all associated with increased risk of mortality from COVID-19. Dr. Alessio Cortellini presented an update of the TerraVault data at AACR this year, including 581 patients from our database, including 66 or 11% of patients with small cell lung cancer. And unfortunately, we see that our small cell lung cancer patients do even worse, with an all-cause mortality of 42% compared to approximately 35% for our other cancer types included in the TerraVault database. We also see that these patients were more likely to have were not necessarily more likely to have stage 4 at the time of diagnosis, but were likely to be on therapy at the time of their COVID-19 diagnosis in 82% of patients. Now, there's a lot of data that's emerged, but there's limitations in the data we've seen, as well as conflicting results on the impact of immune checkpoint inhibitor. These databases have shown us different endpoints of death versus hospitalization versus oxygen requirements, and sometimes those all together come up to make a severe COVID-19 patient. The data does not tell us if it matters exactly when the cancer therapy was started. It is unclear on the presenting symptoms and how they may impact survival aside from shortness of breath in the UK coronavirus project. It's unclear on the time of COVID-19 relative to the pandemic in a given city or country and how hospitals were taxed and had to make difficult decisions in terms of hospital admissions and ICU. There's no clear data on what therapies were administered to treat COVID-19 and how they impacted outcomes, beyond telling us that hydroxychloroquine may have hurt some of these patients, but for many of these patients, they were administered multiple therapies all at the same time. Does it matter if a therapy is administered alone or in combination with other therapy? And what about these patients who have immunotherapy and if they had a prior adverse event with immune checkpoint inhibitor therapy beyond pneumonitis? What if they had colitis or panhypopet or adrenal insufficiency? Does that potentially impact their overall survival if they get SARS-CoV-2? There have been many societies, including ASCO, that looked at the impact of COVID-19 on the conduct of clinical trials. They tried to learn about the challenges and changes conducting trials in COVID-19, and initially had 32 respondents from 18 community and 14 academic sites. They found that there was a decrease in patients' ability or willingness to come to the sites and limited services such as less radiology, surgery, cardiology, and labs available to patients. Staff took time to organize and implement telehealth for approximately 55% of patients, and CROs were sending out ineffective, duplicative, and inconsistent communications with their sponsors. They also looked at what was some of the major changes in oncology practice, and telehealth visits went up by 88%. Patient review of symptoms were suddenly done over the phone more commonly, even for trials. Remote care, such as clinical imaging and lab assessments closer to home, oral drugs being shipped to patients' homes, and remote consenting. With many research staff working remotely, CROs monitoring remotely, case research only visits expected for those patients who had to have IV therapy, and unfortunately, including our own cancer center, limiting screening or halting screening for trials and prioritizing trial enrollment as the pandemic evolved. There are also now guidelines for thoracic patients from societies, and I'll highlight ESMO's guidelines because they really look at it by different tumor types. Cancer patients are prioritized as high priority, medium, and low priority. High priority are patients who have immediate life-threatening or clinically unstable, or the magnitude of benefit qualifies for the intervention as a high priority. A medium priority patient is a patient's situation is not critical and delay beyond 6 weeks could potentially impact overall outcome, or the magnitude of benefit qualifies for an intermediate priority. And a low priority patient is stable enough that services can be delayed for the duration of the COVID-19 pandemic and/or the intervention is not a priority based on the magnitude of benefit, such as survival or quality of life. Now, there's outpatient management, which I'll highlight on the left, and that for medical oncology, but I will direct you to look at this website because there is data for radiation oncology, surgery, imaging guidance. And again, those outpatient visits, those high priority, those new patient diagnoses with disease-related symptoms, and we think that they have a stage 2 or higher cancer. And their visits are for treatment administration. The medium priority are the diagnosis of a suspicion or a localized cancer that's clinical stage 1. Post-operative patients can be seen with no complications via other methods. Follow-up for patients at high risk of relapse or established patients with new problems or symptoms that may require treatment. Those low-priority patients are the survivor visits, follow-up patients with low risk of relapse, or patient visits for psychosocial support, and those should be potentially converted to telemedicine. So where are we now? We know that patients with cancer are at increased risk for mortality from COVID-19 compared to the general population, and that patients with lung cancer appear to be particularly at risk. The cancer patients appear to be less likely to be offered ICU-level care, and there's conflicting data on which comorbidities impact survival, but we know that the presence of any comorbidity is a factor. It's unclear which therapy is associated with worsening survival, but chemotherapy and maybe immunotherapy are. And there's no clear evidence on what available therapies for COVID-19 may impact cancer patient outcomes. And I think it's also important to remember that despite many of the vaccine trials that are out there, the outpatients are not currently being included in these studies. And it's important to think about this when and if a vaccine becomes available. I want to thank you for your attention and thank again to Dr. Garasino for having me here this evening.
Thank you so much, Liora. I would like to advocate again for the participation to the TerraVolt trial. You can find all the instructions on the specific website of the TerraVolt. There is also one part which is totally dedicated to the patients, and I think that it is really important also to see the patient perspective. And I again would I would like to advocate also for clinical trials with the vaccine in this particularly frail population. So having said that, I'm going to go to the conclusions of the Congress, and it has been a great pleasure to have all the speakers here, all my group, and all the people who joined the event. I would like also to acknowledge again events for creating this incredible situation. Clearly we are in a virtual situation, so unfortunately behind there is not really the skyline of my city, but you can see something. I would like also to acknowledge all the pharma companies for giving us the support for doing these incredible events. Yesterday there were a lot of people who joined the event, and also I see also today. And the event will be online virtually in streaming, so you can join also on YouTube all the presentations. Having said that, I enjoy to have a wonderful day. Thank you for your attention.